And honestly, it doesn't. I don't just get my part. I was like, summer session. Tuesdays, there's I think like so like
it's looks like different types of races. They have the actual like Indy car, but they also have like modern car. They have like old school cars.
Yeah, I've never gone.
Yeah, it's in the downtown. Like the restaurants are in the
Stats, right?
Stats.
Like data analysis.
You're just like
Is that you? My coworker, I was like, if you don't like it, stop. I'm very proud. Reminder better play next week, right? Okay. Are we training again? We sang to your spirit. Are we training again?
No, I love it. This is not me saying it, like she said it herself. I think it's like a little bit.
And then this too.
Sometimes she just does shit that's it.
Going to.
And she gets the material across. It's super low stakes. Like you'll have an A plus.
Two of my orange are nominated. Thanks, you too. Like the and I didn't want to.
All right. Hello. Hi, everyone. Good morning, good afternoon. It is so beautiful today. I hope everyone's been enjoying the beautiful weather so far. We have a lot of exciting things planned for today's meeting. First and foremost, we have Mr. Ryan Lay, who will be presenting Seminole Course. This is a very, 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 very popular UTeach course, Ethics in the Emergency Department. Very awesome course. So show this whole syllabus, it's incredible. So we're going to be going through a class of his, but before that, we have a couple quick announcements to go through.
Okay, first off, as always, we're gonna start with selfies of the week. That's what we got here. Okay, here. All right. Oh, we got Luke. Who wants to reach? You want to talk about it a little?
Dyson Daniels. I was so happy. Like, he was in Irvine. Like, this is BS. Yeah.
Who is Dyson Daniels?
The great barrier that don't know. How do you spell it?
DYSON space DA.
Oh, there we go. He's an Australian basketball player in the NBA. For the Hawks too. That Atlanta.
Steel stats.
Atlanta Hawks.
Koi took a picture.
Also PJs?
What the
Was it like Suitcase or what?
It was Sunday.
They're just like, guys, I don't care about the $4. Let's go.
But yeah, Dyson Daniels.
Dyson Daniels at PJs. Wow, only good things at PJs. Oh my gosh.
Yeah.
I'm gonna go there from Suitcase after this actually.
Hey, Susan. Oh, yes. Why don't we do like an MRAP like social Suzuki one day?
I wrap Suitcase.
So down.
On me.
Oh, he said it.
No, I'm
Okay.
kidding. No.
All right, we got a bunch of like little like head going So like camera, like look at like we go like and then look again. So
Shout out to Luke who went to Philadelphia on Wednesday night, took a red-eye flight, woke up at I think like 6 a.m. to present and walk around SEM. Then not only that, was able to crush pizzas and Philly cheesesteaks the whole way.
Hell yeah.
Luke, tell us about SEM, man.
It was pretty cool. Not as cool as meeting Dyson Daniels. But, the food was great. It's cool seeing the doctors there, and I hope you guys get the opportunity next year because it's fun. Yeah.
How's Philly?
I'm more of a Boston fan, so I don't like the Sixers, so the city's okay. But everyone was really nice there. I thought they'd be mean, but they're cool. So, yeah.
Cool. Definitely encourage all of our newbies to apply for SEM when time comes around that. We and our academic coordinators will help facilitate that.
cross that bridge when we get to it.
Cross that bridge when we get there. Next, couple of really exciting things. We had some rappers present at Europe, please.
Wow, it was absolutely amazing. Everybody was walking around, checking out everybody's posters, lots of good conversations, good questions. It was fun, it was really fun. But the best part, we have something to celebrate, there's something special going on. Our very own M-Rappers, Oneeb and Anne, won Best Poster Presentation out of more than 900. Does have any words?
Speech.
Well, I want to thank me because I felt really bad. I was only able to be there for 2 of the judges, and Omid hardcore carried for all 4 of the other judges. So, thank you.
Thank you, Anne. I would say it was really surprising. I think we weren't really expecting it, but I think what really helped was we were whenever the judges were there, we were engaging with them very, very intentionally, like the eye contact, the very intentional, just directed at the judges, and I think that really helped. But yeah, we were super excited to find out.
Just proper poster presentations, because this is incredible. Out of 900 posters to get past poster presentation is just something else. So again, huge congratulations to you too. Also with that, we have a couple of really exciting announcements. Not only do we have something to say, we also had we had an incredible pool of applications for these past 3 positions that we opened up. Again, it's always competitive and it's always so difficult to make these decisions. There were some incredible applications, really well written, but we had 3 incredible standouts. For those that didn't make it, it's totally all good. There's so many new opportunities that will come up, and something that we always encourage for all of our M-Rappers is just to keep on applying. But we have 3 positions to announce. So let's go for a drum roll, please, for our first position. For the M-Rap Secretary, Andrew. Meeting with you, and we'll be saying a group chat. So go ahead and get started. You want to announce the historian?
Yes. All right.
Sammy, I think.
Next to the M-Rap historian, whoever's going to be taking our pictures. Drum roll.
Gave us some absolutely beautiful pictures and this really lovely, cute video that we absolutely love. We'll share with you guys one day once I have it pulled up, but it was an awesome video that he has. And an awesome edit, yeah. So, yeah. The M-Rap historian, and then do our academics want to announce our very own. Go ahead.
Yeah, congratulations to Joseph.
Oh, sorry. Congratulations, Joseph. And so, Akil and Joseph, you guys can facilitate a call together along with one of our academic coordinators. So we'll try to facilitate a 3-way call of some sort. Yeah. Awesome. All right. Cool. I don't think we're going to be releasing any positions this week, but something to keep in mind, and I think we created a tentative list. We'll release it after meeting today, but there's going to be all sorts of positions. So social coordinators will be one big application coming up soon. And we're going to open up 2 to 3 positions for that. So for those that are interested in social coordinating, getting all of our socials together, really all about building M-Rap culture. That's super huge to us, super important. We're really looking for those that are dedicated and interested in that, as well as a bunch of liaisonships, which we'll send as a comprehensive list after. All right. And then, yeah.
Yeah, so keep working through your newbie checklist. Sorry, I got the date wrong for the proposal that's due a week from so next Monday. And then fire training. So if you have your computers, get them out right now and sign up. I think it's tomorrow morning at 7 a.m. So if you haven't done that yet, please do that like now. Question?
Oh, not for me, but more for like people that are returning members. Do they also have to do it? Does the fire training expire within the year?
I called UCLC. They said it does expire within a year. I have not signed up. I don't know if I want to do it. I'll do it, but I don't know. Yeah.
The most important thing is that our newbies get that completed. And we're taking note on the checklist. So again, as soon as you do it, check off on the checklist because we're probably going to be bumping those that haven't done it after meeting today. Just going to be sending you guys individual texts. Nothing scary or anything, but again, we need you guys to do it now because it's tomorrow morning. So
And for those of you that haven't done it, it's literally just a Zoom meeting and you can, if you want to just sleep through it, that's fine. Just there's a few Zoom polls that you need to, I think for attendance purposes and you're good, right? Obviously, like, yes, like know your fire safety protocols and stuff, but with it being in the community, like a lot of the things they say aren't like super relevant to our situation.
Yeah, it's super low stress, so just like sign up for it. Like,
any questions on that? It's like, I think if I'm not mistaken, there's maybe one in like June-ish, but I don't think there's one. I think we really needed this one because it's gonna be really tight with the next fire.
If we're not doing 199 over the summer, then we don't need to do it.
Okay. Any other questions?
yeah, question.
Yeah, just make sure to pay attention to those deadlines that we set in place. So if not, we'll be just bumping you guys, but no worries at all. All right. Anything else? Oh yeah, orientation day. So we have solidified an orientation day for our newbies. It will be 1:30 to 6 p.m. So right after everyone's classes. And so we're gonna be having all sorts of stuff. We have a pretty comprehensive schedule planned for that day. So we're really looking forward to hopefully you guys having a great time as well as getting on board with the whole MRAP process. Yeah, Krisha?
Yes, so tomorrow at the ED offices, there's going to be a resident research day. So all of the ED residents are going to be presenting their studies, all the data they've collected, conclusions, etc. It's from 7:30 to 10 a.m. tomorrow. If you are interested in going, because it's open to everyone, please scan that QR code and let us know that you're planning on attending. Preferably by the end of the meeting, but like if you really need to like check your schedule or something, then by like 7 tonight at least, because we need to let them know how many people are planning on attending. But super cool opportunity to just get to know what's going on, like research wise.
And then Emma, secretary, would you be okay with including it in like the meeting notes after you sign up?
Our plan.
Oh, yeah, you're on top of it. Yeah,
Awesome.
yeah. Thank you.
Thank you. Yeah, I think we have to cap it at around 8-ish people. They just said that like that's like all of MRAP can go. So the earlier you RSVP, the higher the wait list you'll get. So just keep that in mind. So yeah, we'll send you guys more details once we confirm about this. All right. Awesome. Next, we sent a returning veterans form for the MRAPers for the current veterans. My bad on the link. The link is updated. Thanks, Jolie, for sending that updated link. It's really important that we have all of our veterans fill it out. If you guys don't fill it out, we're going to bump you guys because we really want you guys' feedback from the program from this past year, as well as a couple of other pieces of information. Will you be continuing with your studies and the whatnot and the like essentially. So we're looking for you guys to fill out that returning veteran form so that we can get feedback. Know if you guys are going to be continuing MRAP as well as just general information that we have. There's a couple other questions that we have. So that's that for the returning veterans. It's also in the Slack channel, so feel free to do that now or whenever you get the chance.
Okay, so for banquet, that's gonna be on Sunday, June 1st, 2025. We confirmed the time from 5 to 8 p.m. So if you haven't RSVP already, please do so. It's QR codes, we can get an accurate head count for food and everything. It's gonna be dress code is Sunday best or like semi-formal. And it's gonna be at Dr. BC's house. So after you guys RSVP, we'll send out another email with like the address and everything. It's gonna be a really good time. So food, drinks, some cute superlatives, and then we'll have faculty and senior speeches. Seniors, they'll just be like a minute speech. So don't stress about it or anything. It's just like call you up, give you the certificate, you like talk about your experience. But yeah.
The deadline for RSVP is the 23rd, so please, like ASAP, please.
So I think that wraps up. Oh, never mind. No, we're doing quick numbers and updates for today. With our newbies and veterans. Numbers were looking all right for this week, so no need to. I think we have a couple point special shout outs. Something that we didn't know from last week was Tyler and Krisha hitting a 21.5 point shift. That was awesome. Shout out to you guys for that. I don't even know you did. Was this a semi? Wow. Enrolled for semi, so that's awesome. Yeah. Cool. Knocking out semis, FIs, TCASs, 8 TCASs, incredible. Besides that, everything was looking great for this week. Let's go through all the different studies really quick. B, study updates.
Study updates. Congrats to the new liaison. Other than that, yeah, Joseph. Other than that, no major study updates for the NRAPers or anything. I got in touch with some of the med students that are finishing up STEP and stuff like that. So we're gonna try to get a transition call going. But early June, end of May, definitely before graduation.
Thank you, awesome, Luke. TCAS, Cassie.
Yeah, no major updates. I just want to shout out Ashley and Isabella though for helping with the poster and presentation for your op. They're amazing. Thank you.
It was such a cute poster. Oh my
Yeah.
gosh, babe. I have to go back to it because it was so cute. Hold on.
I like colors.
It was like very like
Oh.
Barbie, very like.
Barbie.
Yeah, that's like.
So cute. I loved it when I saw it in person. Oh my gosh. That was amazing. All right, and then food insecurity.
Oh, advice. So Marco and I presented at Europe on Friday, and then besides that, we have the gift cards, so yeah, just keep enrolling. And thank you for it.
And then we just want to get some feedback. Has everyone been all right with the nutrition security screening?
Oh, yeah.
Has it gone smoothly? Okay. Yeah, Emma.
It has been fine, but I do think that the questions on this survey are a bit difficult to read because it says like I, me, like while I'm trying to read it, I'm trying to understand the question. So that's my only critique, but so far it's been good.
Awesome.
We'll look into that. Thank
Yeah,
you.
Thank you. BTW.
Yeah, so we also presented at Europe. It went really well. I'll be meeting with Dr. Barrios next week to get this second phase or second step of BTW going. Expect to start enrolling for BTW sometime in the summer.
So, and also, wait, I remember seeing a beautiful, cute little picture. Hold on. Hey! Oh. Tyler! At Sonoma! Tell us about it. How was it?
I was okay. I just stood there. Nobody asked me any questions. So
Okay, that's what I did.
Okay, but you got your own screen, so it's a win. It's a win. We'll take it. We'll take it.
Oh, yeah. Awesome. And it's PI?
Still working with Salon. We're progressing slowly but surely. We also presented at Europe. Shout out Leilana for helping me out with that. Just like a little aside, because I thought it was interesting. There was this one oncologist, pediatric oncologist, who works at the Children's Center, and he does research on pain management as well. So he like grilled us on everything regarding the study, like the methods and the results, and et cetera, et cetera. But apparently he really liked it. He really enjoyed the study, and he was like, check out more about it and stuff like that. So it was a cool experience.
Yeah. Awesome. And then wrist fracture.
Same thing. Me and Josh were able to present it really well at Europe. And then we were able to get the gift cards. So I didn't know well. But no make sure.
And then diabetes.
No new updates, but thank you guys for all the inputs.
House. Go.
I don't think we have any updates. Just keep enrolling, guys. We got the points. Hope you guys can enroll more.
Awesome. And then naltrexone.
No real like big updates, but I guess just want to remind everyone to add me or Mia to the chat whenever you are messaging a doctor, because there's a few people who remind everyone.
Do I use carotid?
We're on hold, so don't do carotid for
Is it just an IRB exploration?
now. Yeah, we're figuring it out, so just don't do it.
Okay. Also, histology. Brandon's sick. ESBB.
No updates, into the screens. The approach.
And then PC.
No major updates. We need 3 more enrollments to reach our goal. So if you guys could prioritize that, that'd be amazing. We can do it, guys.
Good to hear. PE passing.
No big updates. Please keep reading. We were stagnant again. I saw we got that approach, so I think it's whoever did that. Who did the approach?
It was Josh and Philip.
But yeah,
They're not
please
here.
keep reading.
And Stephanie?
Just keep it rolling. I have to come through the data with the ultrasound fellows, but they wanna keep getting data in the meantime.
Okay.
Yeah. Keep it rolling.
Nice. And then Sarno?
Go get this.
Also, cool. You.
Without further ado, tell us the last part. All right, let's welcome our fellow MRAP project.
Oh,
I added a slide just right now.
Oh.
yeah, we can also just navigate to your slide presentation.
Okay.
Oh, did you add it? Oh, you added, yeah, that's.
Oh.
Yeah.
Sorry.
No, no worries, no. Work on slides.
It was like, I was like, oh, should I do this?
Yeah. Oh, okay. Oh, yeah, that's. Alright, hello everyone. Thanks to MRAP for letting me speak and give my ability to teach lesson. So for those of you who are new, my name is Ryan. I'm one of the MRAPers. I'll be graduating this year, so you probably won't see me next year if you're a newbie. But they have me here to talk about and give one of my UTeach lessons. If you guys don't know, UTeach is a program at UCI for undergraduates, where they kind of have you create your own class to put up on the schedule of classes to teach other undergraduates. It's really small, it's like 20 students per class. But it's a really, really cool program, and if you haven't heard about it and you're interested in it, definitely check it out and talk to me if you're interested. But my class is about ethics in the emergency room. This is like the informational panel they have on the website about my class. And pretty self-explanatory. I talk about ethical dilemma that arise in medicine and specifically in the ER. And through MRAP, I've been able to learn so much about like how the ER operates, so I share with my students in class. So the lesson that I'm going to teach to you guys today will be the lesson I just taught last week, so week 7. We discussed EMTALA and ED misuse. And I feel like it ties in kind of to all the stuff that you'll see as an MRAPer in ED and a lot of the studies that we do too. So hopefully this will be informative to not just the newbies, but to all of you. So this unit that I have is talking about medicine kind of as a commodity. So not as like a human right or not as a service, but as something that you buy in exchange for people. I love Dr. BC and I love all his analogies. So I really push the emergency department is like a New York subway in my class. I have a picture of the subway up there. They treat everyone. There's no discrimination, whether you're very poor or very rich, you can ride the subway. Just kind of like the ED, whether you're very poor or you're very rich, you can end up in the emergency department. The thing is, with the subway, you have your Metro card. Some people can afford this Metro card, some people can't. Kind of analogous to the ER, some people can afford that cost of emergency care, while others can't. So that kind of raises the question, if someone is unable to pay for the subway, it seems pretty justified that you just don't want the subway. But in terms of medicine, especially emergency care, is it justified to deny someone care just because they can't pay for it? Specifically because, emergency care so different. You need that care right away. You don't have time to kind of suss out all the details of your finances. So before I have you guys think about that question, here's a statement from a particular person. He said, medical care is neither a right nor a privilege. It's a service that is provided by doctors and others and to people who wish to purchase it. What do you guys think about the statement? Do you have any show of hands? Yeah, go.
Controversial, but could be regarded as believed by some that have always had healthcare and never really experienced any sort of discrimination against it, or had access to it, like didn't have access to it.
Yeah, it's a very seems like a very privileged statement. Seems like it's coming from someone who was never on the other side of healthcare. This was said by Dr. Robert M. Said. He's a cardiothoracic surgeon. This was a long time ago, I think the 1970s. He actually wrote an an article that was published in the New England Journal of Medicine, so a pretty prestigious journal, where he kind of refuted medical care as a right. Obviously, this was pretty controversial. In context, it was written kind of after the implementation of Medicare and Medicaid. These laws kind of put a lot of constraints on physicians financially. So a lot of them view this as a threat to their autonomy and a threat to their independence. But still, a lot of them thought this was kind of too far, it was really controversial. Medicine was kind of seen as like a service-oriented profession. It has a very humanistic outlook, very service-based. So yeah, it's highly controversial. But I think it highlights a really important aspect of medicine, especially ethically, that finances and payment are such an integral part. You can't really have service medicine without paying the doctors and having each service be compensated. So this yields a set of very unique ethical issues. So I just took that question and put it to the top. And really these issues can be grouped into three main categories. So one, access and equity. High cost can limit care for low income individuals. So think about it, let's say someone doesn't have the money to see the primary care physician, might skip their checkups because they just can't pay for it. That's obviously bad for their health. Profit versus care, financial incentives may compromise patient well-being. Think about like big pharma, they sell insulin for so much when needed to live. These economic incentives can kind of jeopardize patient care. Also, resource allocation. Think of how busy the ED is, how much resources you have. If they aren't able to finance those costs, then it might shut down, which could lead to these patients not having anyone to care for them. So a lot of tension between finances and patient care. So a quick history lesson before we jump into EMTALA. For context, public hospitals usually receive funding from the government, so they can more easily pay or eat the costs of patients that can't pay for the care. Meanwhile, private hospitals, they take these costs a lot more severely. So let's say if they go a long time without serving a lot of homeless people or a lot of patients that can't pay for their care, they might go under, they feel these costs really heavily. So that's just for context. In the 1950s, Americans usually had health insurance because health insurance usually covered ED care. So all of these EDs were very well funded. If they had someone come in where they couldn't pay for the care, they can cost shift. So basically this means they just charge more for the people that can pay, and they just cover the costs of people that can't pay. So this kept a lot of EDs afloat. In 1964, they implemented Medicare and Medicaid. So this helped the the public hospitals get some funding to treat these people that aren't able to afford care. But with Medicare and Medicaid, it was very unorganized. These physicians knew that they can kind of charge anything to this patient, and it'll be covered by Medicare, by the government. So they were kind of just draining the government of this subsidized money. So in 1983, Medicare, they made some changes to it. So you can't kind of just charge whatever you want, have it compensated. And because of this, this prevented cost shifting. So now they can no longer cover the costs of people that can't afford their care by increasing the price for people that could afford the care. And because of this, this led to a really big problem called patient dumping. And there's a video I have. This is from a documentary about the emergency department in general, about its history, its conception, and how it started as a specialty. Here they talk about specifics of patient dumping, and it's really kind of shocking to hear about. So I'll put it up for you guys. No, I don't have to fix audio.
Oh, no,
See if it works. It's not too loud. It's always happens. The audio, right? Let's see. Oops, 1 second. Yeah, that's what I'm thinking. If not, I can just kind of give a synopsis. Oh, super short. I think we are kind of short on time, so if you guys don't mind, I'm going to put it at like 1.5 times speed. Okay.
For better or worse, emergency doctors are governed and guided by their conscience. They've always been among the first to stand up for people in need who are neglected or ignored.
We're like the Emma Lazarus poem under the Statue of Liberty. Send us your poor, you're tired, those people without insurance, and we'll take them in.
People who couldn't pay for medical care were once routinely turned away from private hospitals and delivered to public hospital ERs, like the one run by Arthur Kellerman in Memphis, Tennessee.
It was a morning shift. 2 Memphis paramedics were rolling up the hallway with a patient. I knew this young man is critically ill. And I'm going to do my primary survey. I'm checking airway, I'm checking breathing, and I reached to check his radial pulse. And I brushed a bright, mint condition yellow hospital wristband. Now, this is important because my hospital's wristbands were powder blue. And I flipped it over, and it was the name of a very well-funded private hospital in Memphis, about 6 blocks up the street. And I said, what the hell is this? There's no IV, there's no paperwork. And he goes, oh, didn't we tell you, Doc? He's a transfer. He's indigent. I was livid. I was so disappointed at my colleagues up the street. I thought, how could any physician not stabilize a 19-year-old because he owed you a bill from your last ER visit? They dumped him. This was dumping at its absolute worst. Raw, in your face, go to hell, dumping. So I got this crazy idea one day and I said, I'll tell you what, I'm gonna buy a dinner for 2 for the nurse who collects the most wristbands by the end of the summer.
It wasn't long before Kellerman had collected plenty of wristbands. They would play a crucial role in transforming patient care when he testified before Congress.
At the end of the hearing, I said, I've described several hundred patients who are transferred, but you're used to dealing with much bigger numbers, millions and billions. But these are people, these are humans, these are Americans like you and me. And I reached under the hearing table in Congress, pulled up the bag of wristbands, and I dumped it on the table. The cameras swoop in, the congressman leaned forward, the murmur starts, and I said, this is just 90 days of dumping of poor folks to one hospital in one mid-sized city in the Mid-South.
And that became the EMTALA legislation and the requirement for people working in the emergency department to provide acute evaluation for all patients who present to the emergency department and to provide the acute care. That was a remarkable legislation that has had probably the most profound impact on the care in the emergency department.
EMTALA, the Emergency Medical Treatment in Active Labor Act, was a landmark. It prohibited patient dumping. No hospital emergency department could refuse to treat a patient because that patient couldn't afford to pay. Overnight, ERs became the health safety net for all Americans.
And that's always been the mantra of emergency medicine that goes all the way back to Jim Mills. Anyone, anything, anytime, we're going to be there for you. And EMTALA codified that. But really what it did was made sure that everyone was living up to those ideals.
Right, so the gist of that was these private hospitals started seeing patients that they knew couldn't afford emergency care. As a result, instead of treating them, they just kind of dumped them to the public hospitals who they knew got extra funding for this type of stuff. Obviously, a very unethical practice. If someone needs emergency stabilization, you should treat them immediately. You shouldn't transfer them to another hospital. So because of that, EMTALA was enacted. So EMTALA is a federal law that was passed to make sure that this patient dumping didn't take place. It required emergency departments to do 3 main things. The first of which is screening. So they must evaluate anyone who comes to the ED to see if there's a medical emergency. For you MRAPers, if you ever hear on the overhead, oh, Dr. BC to trauma hallway for an MSE, this MSE is a medical screening evaluation. And this evaluation is to make sure for EMTALA that these patients are seen first without, before being treated or before being discharged. Second of all, they require stabilizing treatment. So if there's an emergency, they must stabilize that patient. So these hospitals, if you receive someone that needs to be stabilized, even if they can't pay, you're required to stabilize them. And then lastly, transfers are restricted unless pretty much it makes sense if there's a benefit to the transfer. So you guys know those signs that say like no shirt, no shoes, no service on restaurants. This is kind of like the reverse of that in the ED. It's saying even if you can't pay for care, it's the law that we can care for you. Pretty sure that this sign is also in the UCI. Not exactly sure, but many of you can point out to me, that'd be awesome. But yeah, a really great piece of legislation. As a result, patient dumping was ended. Hospitals can't transfer insurance patients unless it makes sense, unless they're stable. And most importantly, it affirmed healthcare as a human right. So it's in the public view and with physicians, they kind of agree that emergency care is a human right that all humans should deserve, even if you can't pay for it. However, while it was kind of universally hailed as a pivotal law, there's some problems that arose with its implementation. I'm sure some of you guys might have thought about it or noticed it when I explained EMTALA to you. Can you guys kind of think of like what might have gone unnoticed or unchanged with EMTALA? And as a hint, remember that the reason why patient dumping was occurring was because these private hospitals couldn't afford treat these patients. Yeah, right.
I guess like the criteria about stabilizing is not super defined and like the people have to like once they're stable they can throw them out they or something like how much post initial stabilizing can they like stay in the hospital?
Yeah, I guess that's kind of under their discretion of the provider, so there could be some hiccups there. Emma, I saw your hand.
They're not like addressing the financial strain put on this private hospitals.
Exactly, yeah. So EMTALA is unfunded mandate. So they didn't really fix the root cause of the problem. They just kind of said, hey, you can't do this, you have to treat these patients. So because of this, financial burden is kind of like the main biggest consequence of EMTALA. So in my actual class, we teach really emphasizes like group work and active learning and that type of stuff. So I would pass out a worksheet to go through an activity, but just for the sake of the meeting and sake of time, I just go through it with you. So I gave them a list of different scenarios, and each of these scenarios kind of highlights a benefit and also kind of like an unintended drawback of EMTALA, and how to build the chart. So we can look at the first scenario. Does anyone want to help me read this one? Do like a popcorn read session? Yeah, Isaac, it's here.
Dr. Lopez finishes treating an older man for a wound infection. However, after treatment, he finds out that the patient is uninsured. Although he is glad to have been able to care for the patient, he is saddened to know that the hospital must absorb the costs and add to its mounting debt. Recently, the hospital had to cut staff due to financial losses. Dr. Lopez is afraid that with more strain, this small rural hospital may be forced to close its doors.
Yeah, thanks for the reading. So yeah, this kind of highlights the financial burden that's placed on these private hospitals. So in that chart, the benefit of EMTALA is that it allows for equitable care even if patients can't afford it. But because it's an unfunded mandate, this places a severe financial burden on hospitals, especially small hospitals that serve rural populations. This hits them really hard because rural populations, they see so little patients and a lot of these patients are unable to afford it. So the consequence is that the hospital just shuts down. And it's kind of like an unintended effect. All right, second scenario. There's 4 of these, by the way. So hopefully it's not too many. But does anyone want to read this one for me? All right, guys. Yeah, Paul.
All right. Sarah, a 25-year-old barista, waits in a crowded ED with a mild sore throat. Due to her low income, she can't afford private insurance and she doesn't qualify for Medicaid. Without insurance, finding a primary care provider is almost impossible, as many clinics refuse uninsured patients. Sarah lies on the ED because EMTALA guarantees treatment, even for non-emergency issues. Unfortunately, many other patients are here for the same reason. As a result, the waiting room is overcrowded, occupying space and resources that are usually reserved for more critical cases, like a car crash victim rushed in shortly after.
Thank you. So I'm sure a lot of the MRAPers can kind of relate. If you walk into the waiting room to screen for a buy or whatever, sometimes it's just freaking packed. There's just so many people can barely move and walk around. So with EMTALA, although it guarantees that patients that don't have access to primary care can always get care in the emergency department, this overcrowds the hospital because there's so many patients like this, especially in the area like in Orange and Santa Ana, the people that come to the UCI Medical Center. This can really kind of clog up the hospital and take resources from those that are there for real emergencies. The third scenario, I guess I'll just read this one. So the ED is disrupted by loud screaming from the waiting room. A man with a minor injury is becoming loud, rude, physically aggressive, due to frustration from long wait times. When told that he must calm down or will be forced to leave, he shouts, "Can't kick me out. I know you legally have to see me here first." He does not suffer from any mental illness. He is just difficult and manipulative. Despite his behavior, EMTALA requires that the staff must still evaluate and stabilize him, which disrupts care for other patients and adds stress to the staff. So this scenario was actually recommended to me by Alex, the pharmacist, when I was kind of consulting him for this lesson. And also when I was browsing just like forums of doctors for their opinions on EMTALA, this is probably the most common one. Regardless of how the patient is treating you or how the patient is acting, you must see them required by law because of EMTALA. So while it allows everyone to be screened for their critical injuries, it prevents bias from the doctors in case you don't want to screen them for whatever reason, for their attitude or whatever. Manipulative patients can still take advantage of this. Be as mean as you want to hospital staff. It makes their lives a lot harder. It's just a really bad unintended side effect, unfortunately. Last scenario, so David, a 34-year-old construction worker with insurance, suffers from chronic back pain. Instead of seeking a PCP, David knows that under EMTALA, the ED must treat regardless of his ability to pay. When his pain flares up, he gets the ED, even though it's not an emergency. The hospital evaluates him, gives him pain relief, and sends him home. No questions about payment. Over time, David uses the ED regularly, even though his condition could be better managed by a PCP. This misuse takes up resources meant for real emergencies and places strain on the system. So I'm sure for the MRAPers that have screened FTH before, maybe for those leads, if there's exploring factors points, you can notice that some people are here for reasons that don't seem like real emergencies. They seem like they could be easily managed by their primary care provider. And that's another unintended side effect of EMTALA. It really encourages ED misuse because if you present to the ED, they're going to treat you no matter what. They're not going to say, oh, we don't really do that here. It's your primary care doctor, whatever. They'll treat you for whatever you need right then and there. So another unintended drawback. So with all this data that we kind of talked about, I kind of asked my students, what changes would you make to EMTALA to improve emergency care? And also what changes would you make to just healthcare in general? The answer that I'm trying to get them all to kind of converge upon is that there's nothing really inherently wrong with EMTALA. If you change EMTALA, this hurts the population more than it helps it. The people that kind of rely on the emergency department for care will no longer be able to receive that care. So really, all of these drawbacks kind of come from the healthcare system in general. So some key takeaways from just that whole activity. EMTALA was enacted to ensure that those with financial barriers can still receive care during emergencies, even if they're not able to pay for them. Unfortunately, just how EMTALA is set up, it leads to some unintended side effects. So this creates an ethical dilemma where you weigh healthcare as a human right versus the financial resources of the hospital. And solutions aren't really within changing EMTALA. It's more systemic. There's large-scale changes that need to be made to the emergency department. So what are these large-scale solutions? They're pretty difficult, and I don't think we have the solutions right now. And if we do, it's definitely outside the scope of my knowledge. We're just an undergrad teaching this class. But I can confidently say that since these problems are so prevalent in the ED, a lot of organizations are trying to solve them, including UCI, with our wonderful MRAP program, is doing a lot of research to try and help these problems. So to solve these problems, we ask some questions first and how we can solve them. So can we evaluate the presence of ED misuse, one of the biggest side effects of EMTALA? How can we identify reasons why patients choose the ED instead of the PCP? Can we use these reasons to reduce ED misuse and overcrowding? Sounds kind of similar to some of the MRAP studies that we do, namely the exploring factors study that we have, and also the lead ABC study that we have. For all you newbies, both these studies really look at why patients are coming to the ED instead of going to the primary care provider. Once you start screening for the study, you'll see a lot of the questions addresses this kind of gap between the PCP and the emergency department, whether it's mistrust for the PCP, lack of funding, lack of transportation, whatever. Some more questions we can ask is, why do patients choose the ED when they're unable to afford care as opposed to free health clinics or government-provided programs? Why are homeless patients so prevalent in the ED? How can we improve healthcare for these patients both inside and outside of the ED? And can we use these results to give these patients alternatives to care other than the emergency department? The MRAP studies that address these questions, I'd say that are evaluating on housing, food insecurity. Shout out to all of our MRAPers on the screen, Kevin, Julie, Marco, Isabella, and Akhil. Yeah, that's pretty much it. You can see MRAP is really looking to solve a lot of these problems. Hopefully it's something that excites you guys. Hopefully you guys can see kind of the big frame of all the problems that the department faces. And you guys will be able to experience that firsthand once you guys actually start shifting. And you guys will also have an opportunity to participate in kind of the solutions to these problems and the efforts being made to make the ED a better place for everyone, for the doctors and for the patients. So thank you guys for listening. Well, over time, right? Oh, wonderful. All right, guys, let's get some pre-sun.
Any questions, guys, for Brian?
Yeah, Brian, I'm curious. So when you're teaching this to, I'm assuming most of the students are obviously not exposed to the ED. what are their perceptions on like providing healthcare to anyone and like just like some of these topics that were brought up. Do you think it's similar or different to like our experience, I guess as MRAPers and what do you guys, what would you kind of like?
Yeah, so just from all the lessons that I did, this is like a week 7 lesson. So a lot of the front half of the lesson is just kind of establishing those like bioethical principles and like the ethical rules that doctors kind of abide by. So by this time, they're kind of conditioned, they kind of understand that healthcare is very service oriented. They place a lot of value on treating everyone, and finances are kind of like taking the backseat. So they kind of have that same perspective that all these financial problems are in fact problems. Yeah, it's really interesting hearing their different perspectives. Some of them come from different majors, some marketing, healthcare oriented. So, but for the most part, it's generally very good.
Yeah, I think for people that want to get involved with your position, how would you become? It's not you teaching, right? I don't know.
Yeah, it's UT. Yeah, great question. So UTeach operates kind of like MRAP. It's a like yearly application thing. The application cycle opens in spring. I think it should be open right now. You're supposed to go to like little information sessions that are at the start of the spring. But I'm sure like the director explained you didn't. But to apply, you need a faculty advisor. That's probably the hardest part of it. And of course, you need like an idea for a class. So once you have those things, you can fill out the application. You spend the summer and the fall just kind of planning the course. The winter, they teach you like how to teach a course. And then in the spring, you have fun and teach a course. Yeah, it's a really fun opportunity. It's really, really exciting. So hope one of you guys actually applies the cycle. He's a philosophy professor. His name's Dr. Brennan. If any of you guys are like taking philosophy classes or like humanities or anything, he's a big guy. Oh yeah.
So you were talking about like I was pulling up this slide, like what is the EMTALA slide? And then you were saying like something about like restricting the transfer. So you're saying like unstable patients can be transferred in like that outwards.
Yeah.
So what are like some of
Yeah. So the biggest thing I think, especially just in terms of like the UCI Medical Center, CHOC is right there, and they have a lot more resources to service like pediatric patients, while the UCI Medical Center may not. So a really big reason for transfer is if the patient is pediatric, that kind of justify a transfer. A lot of things I've seen is like if the hospital doesn't have like inpatient psychiatric care, a lot of psych patients get transferred out. UCI is very fortunate that it does have ED2 from the psychiatric care. But yeah, before they transfer, they always have to fill out the EMTALA, as the doctor was saying. Pretty much have to describe to the accepting physician like the reason for the transfer. Yeah, good one.
I know you shared the syllabus with us, but I was curious, what were some of the other ethical considerations that you talked about in the course that might be like interesting in general at rappers that you thought were really interesting?
Yeah, I structured the class kind of in 4 main units, or I think 4.5 units. It's really just like what I find interesting in medical ethics and emergency medicine. The first one is just general principles. It was like an introduction to all things medical ethics. The second one is on resource allocation. It's a really big thing in the emergency department. You have so many patients coming in and you have so many limited resources. So I kind of deal with how you allocate those resources. Some examples are like during COVID, they had to give up ventilators for some patients. I remember Kim told me this story. It kind of inspired a lot of lessons. But figuring out who deserves the ventilator versus doesn't. The third unit is on dilemmas of death, so like DNR forms, resuscitation, stuff like that. This unit is on medicine as a commodity, so finances and stuff. And the last one is like very philosophical, it's very experimental. It's like what is an emergency and what deserves to be treated for. Yeah, it's a rough outline. But I think all of them are. Yeah, thank you guys so much for your attention.
Yeah, that's good.
Are you gonna teach this course together? Or is it
Yeah,
one and only, like one?
If any of you guys wants to apply with my slides, I'd be happy to give them to you.
Wow, thank you so much, Brian. That actually does wrap up today's MRAP meeting. Thank you so much to Jolie, who brought the We have any little snacks in the back at the Capri Sun, so everyone's more than welcome to just hang out and enjoy some snacks for everyone's meeting. But thank you guys so much for coming out today. Really appreciate it. That's all for today's meeting.
Hang around if you guys have any questions about any of like the About 199